Welcome to Department of Medicine Grand Rounds today. I'm Allison Bond, the medical director of Grand Rounds, and we have three experts here today who are going to demystify a topic that's a little bit of a tongue twister, connective tissue disease associated interstitial lung disease. We'll be learning about how cutting edge genetics and clinical insights really are coalescing to help with personalized treatment strategies and early detection. So the three discussants are in alphabetical order. Andy Gross, a professor, clinical chief of rheumatology at UCSF Health, and co-director of the UCSF Scleroderma Center. Also, he works in the UCSF Interstitial Lung Disease Program with UCSF physicians, immunology researchers, and other experts to provide comprehensive care to patients with complex conditions. Next up is Rupal Shah. She is an assistant professor and the medical director of adult patient experience in the Division of Pulmonary, Critical Care, Allergy, and Sleep Medicine at UCSF Health. She sees patients on the lung transplant and interstitial lung disease services, and she, in 2022, received the UCSF Exceptional Physician Award. Last but not least, Anthony Shum, professor in the Division of Pulmonary, Critical Care, Allergy, and Sleep Medicine as well at UCSF Health. His lab recently helped discover the genetic basis of COPA syndrome, an inherited autoimmune disorder that can lead to severe lung and joint disease. And he also identified a novel biomarker to detect lung autoimmunity. I'll let them take it away.
Allison, welcome everybody, to those of you here in person and online. We are really excited to talk about connective tissue disease related ILD today. Here are our disclosures, and for today, we're really going to start by talking about what connective tissue disease related ILD is and give you a framework to approach the diagnosis to ILD and the management. And when Andy and I were kind of talking about what do we really want you to get out of this talk, of course, we want you to know what CTD-ILD is and how to manage it, but really wanted to sort of show you the deep partnerships we have between specialties when we manage these cares and how much this is kind of a team sport. So we're really excited to talk to you more about how we practice and then turn it over to our amazing physician scientists to talk about genetic insights into CTD-ILD. So of course, we're going to start with a case. This is a 45-year-old woman. She comes to the emergency room saying, well, I started getting short of breath a couple months ago. Then I started coughing. And at first I thought maybe I was just tired or I had a virus. But then over the past couple of weeks, I've noticed some muscle weakness. It started with having a hard time reaching up to take things out of my upper cabinets. But now I'm really having a hard time just going up and down the stairs. In the ED, her vital signs are notable for hypoxia. Her saturation is 89% on room air. The ED appropriately gets a CTPE protocol and says, oh, this is interstitial lung disease. So they call the hospitalist for admission. Just to level set, so we are all on the same page, what is interstitial lung disease? ILD is a group of parenchymal lung disorders that is pretty heterogeneous. There are many types of causes of ILD. It also doesn't just affect the interstitium. You can get both alveolar, vascular, airway, so it can affect really all parts of the lung compartment. And there are multiple ways to classify ILD. This is sort of a field in evolution. We historically have always thought about grouping ILD by cause. What's the underlying driver of the ILD? But we're seeing more and more that some similarities between ILDs that are caused by different things but have a similar radiographic pattern or progress in a similar way. So they get more and more fibrotic. So as we think about ILDs, we're trying to hold all of these things in our mind as we think about treatment. How common is connective tissue disease related ILD? It makes up about 20% of patients with ILD. That's true across the United States as well as here at UCSF in our ILD program. Because high resolution CT scans are kind of the mainstay of diagnosing ILDs, I wanted to spend just a few minutes reviewing some common patterns that should make you think first of ILD, but then also certain connective tissue disease related ILDs. recognizing that this is the part when we start to get into alphabet soup, right? The big joke about ILD is that we just use a bunch of acronyms. So the goal here is to decode the acronyms. So the next time you see a CT report, you will already be an ILD expert and know, oh, this is what this means and this is what I should do next. So I'm going to start with this pattern, usual interstitial pneumonia, or UIP pattern. This is a pattern of fibrosis. So radiology keywords you're going to see when you see a UIP pattern: subpleural and basilar reticulation, so on the edges and bottoms of the lung, honeycombing, and traction bronchiectasis. Often, the most common cause of a UIP pattern is a disease called idiopathic pulmonary fibrosis, or IPF. So what I want you to remember is that not all UIP is IPF. In fact, rheumatoid arthritis and sometimes scleroderma can cause a UIP pattern. And a UIP pattern is really fibrotic and tends to progress over time. So when you see a UIP pattern, it should be an automatic concern that this is progressive and moving forward with a workup. Okay, the second pattern is called nonspecific interstitial pneumonia, or NSIP, which is actually a specific pattern of interstitial lung disease. Here you'll see subpleural sparing, which means that in general, the fibrosis or inflammation does not go all the way to the edges of the lungs, so different from a UIP pattern. You can get both inflammatory and fibrotic NSIP. So you can see ground glass opacities and traction bronchiectasis with NSIP patterns, but often the disease is more central than a UIP pattern. When I see this pattern, connective tissue disease really comes to higher up on my list. There are other things besides connective tissue disease that can cause causes like drugs and exposures, but really this does make me think strongly of connective tissue disease, particularly scleroderma, myositis, and sometimes rheumatoid arthritis. Organizing pneumonia, you all are familiar with, is a presentation of inflammatory lung disease, often with consolidations. Probably have heard of the hallmark Atoll sign, which is ground glass with surrounding consolidation. Should really make you think that this is organizing pneumonia. Broad differential, including drugs and exposures, but certainly connective tissue disease can present as this, in particular, our myositis-related ILDs. And then I'm just adding this one pattern, diffuse alveolar damage, which has a broad differential. And I just want you to remember, though, that when somebody presents with unexplained hypoxic respiratory failure, acute lung injury, to keep connective tissue disease on the differential, because it can rarely present as DAD. All right, back to our patient. The radiology report says reticulation, consolidation, and ground glass opacities consistent with both an NSIP pattern and an organizing pneumonia pattern. So you know from what I just told you that connective tissue disease is high on your list. She comes into the hospital and you notice a rash on her hands and her CK is elevated at 6,000. So taking all these together, you're really concerned for connective tissue disease. And this is when I make Andy regret that he has given me his cell phone number, because it's always a Friday afternoon. And I call him and say, help, I think this person has an autoimmune disease. I'm gonna turn it over to him.
Cool, okay, thanks, Merkel. All right, so for me, when I get a call on someone like this, usually I'm starting when I'm thinking about, is this an autoimmune disease causing this manifestations? I'm actually going to start with the chest CT. And because the chest CT is going to guide me. There we go. Okay, good. All right, so the chest CT is going to guide me in my differential diagnosis. So this is an oversimplification, but I think it's kind of helpful sort of putting things into context. So left side of the screen, more fibrotic disease with that UIP pattern that Rupal was just talking about. And that IPF is the classic example of that, not an autoimmune disease. And then on the right side is more inflammatory with things like NSIP and even organizing pneumonia. So rheumatoid arthritis is going to frequently cause a more fibrotic pattern. Yes, it can cause more inflammatory, but the majority of patients are going to have UIP or at least a fibrotic NSIP pattern. On the other side of the spectrum, we're going to have inflammatory myositis. That's going to have a lot more NSIP and sometimes organizing pneumonia overlap. Yes, inflammatory arthritis can cause UIP, especially late stage when you have enough inflammation long enough, you get a lot of fibrosis. But at the beginning, like this patient, I'm thinking more on this end, like inflammatory myositis. Scleroderma, MCTD, somewhere in between. Definitely inflammation, but maybe not as much as inflammatory myositis, can be a UIP pattern. So that's where I start. So then where I have to go next is a combination of review systems and my physical exam. So just going through the kind of things I do, So looking for rheumatoid arthritis, key things I'm looking for. So a history of MCP and wrist pain. That's going to be very different than osteoarthritis, which is more DIP, PIP, of course. I'm going to be asking about prolonged morning stiffness, perhaps more than an hour. And of course, I'm going to go looking for joint swelling. I showed a picture from the ACR collection that kind of hints at that MCP and wrist swelling. But of course, to really detect swelling, you really need to do a physical exam. For those of you not used to feeling swelling all the time, sometimes it's just helpful to go back and forth on the joints, left side, right side, to try to feel, oh, wait a minute, that one really does feel more swollen than the contralateral. Okay, so then thinking about scleroderma, key things I'm going to ask about, Raynaud's phenomena, so color changes with cold exposure. Classically, you should have at least 2 of those color changes, so pale or more cyanotic blue-purple, or then reperfusion red. So I'm going to look for sclerodactyly on the exam. I think everyone, like even rheumatologists, sometimes have a hard time picking up skin thickening, but more frequently people actually initially kind of present with these swollen hands that feels kind of tight. So it's not the focused swelling and discomfort of synovitis from rheumatoid arthritis, but it's more the whole hand just feels tight and uncomfortable and puffy. And that can be present in MCTD as well. And then finally, for myositis, so the key thing I'm going to be asking about is proximal muscle weakness. That's distinct from myalgia. Very frequently, people with myositis don't have any or very little myalgia. Of course, I'm going to ask about arthritis and rashes. The arthritis, I'll come back to in a moment, associated with myositis. And then, of course, fevers. So rashes, what are we talking about? So, of course, the classic Gottron's papules are these violaceous purple papules over the knuckles. But sometimes in more early disease, it can show up as a more sort of faint redness over the knuckles. Other people will show up with a facial rash, kind of a more malar pattern, very similar to lupus, although often a little bit more mild. And then the heliotrope rash. This one's actually harder to pick up on. Sometimes it just shows up with just sort of eyelid swelling. But some people actually have the rash. You can kind of make it out there, or on top there. Some people will have more of a hyperpigmented rash. I didn't show it, but of course the shawl sign over the shoulders, and sometimes a hyperpigmented rash over the hips. And then some people present with this more unusual rash, which is called mechanic's hands. So that's going to be more of a hyperkeratotic or thickening of the skin over the hands, like a mechanic. And when I see that, I think about a specific subtype of dermatomyositis, something called antisynthetase syndrome. I think it's a rare thing, so a lot of people aren't super familiar with it, but it's important when we're thinking about CTD-ILD, because ILD is such a common manifestation of it. So antisynthetase syndrome, named after the autoantibodies associated with this condition, that recognize tRNA synthetases. So JO1 is the most classic one, but PL7, PL12, EJ, OJ, we actually see regularly. And some of the other key features to antisynthetase, some level of myositis, although many patients don't have much, or it's subclinical. They just don't complain about much weakness. A lot of people have Raynaud's phenomena. They can present with an inflammatory arthritis that looks exactly like rheumatoid arthritis. So it can be a little tricky that way. And fever can be an important presentation, which obviously makes the workup tricky because you're like, oh my goodness, this person has an infection. But it's an important thing to remember. It can present with a fever. One other important thing to talk about as sort of a subgroup of dermatomyositis is MDA5 disease, especially for the hospitalists. So this is a particularly severe form of dermatomyositis, named for the antibody it's associated with, the MDA5 antibody. And truthfully, when you're a myositis panel, I think for the hospitalists, they're like, much good is that going to do? I mean, we're not even get that until the person's discharged. But so the key thing that you're going to be looking for on these patients is an unusual rash. So the rash that these patients present with is this ulcerating rash, especially on the palms. So usually you think about dermatomyositis on the backs of the hands, but this is going to be on the palms, especially at the creases of the fingers, and eventually that can ulcerate. People can also get ulcers anywhere else, forearms, back of the hands, anywhere else, and they can be pretty nasty. So if you see someone who seems pretty sick and has this weird rashes with these ulcers, get dermatology involved and start looking at their lungs, because this is a kind of lung disease that progresses super fast and is incredibly dangerous. And it's the kind of disease that often we have to use multiple immunosuppressives to manage. Okay, so those are a couple key subtypes of dermatomyositis. This wouldn't be I wouldn't be a rheumatologist if I didn't talk about autoantibodies. So these are autoantibodies that we're going to go searching for in people with ILD. Usually, us rheumatologists like to be a little bit parsimonious in our antibody sending, but in the case of someone who presents with ILD, we already have, based on our review of systems, potentially a pretty high pretest probability for autoimmune disease. So in this case, often we end up just throwing the kitchen sink in. So we're going to look for inflammatory myositis with that myositis panel. It's going to take a little while to come back. Rheumatoid arthritis, of course, CCP antibodies, incredibly helpful for their specificity as well as their sensitivity. The rheumatoid factor can show up in a bunch of these different diseases, so less helpful specifically for rheumatoid arthritis. Scleroderma, the SCL70, RNA polymerase 3 is an important one. More rarely, the fibrillary antibody, and then for people with MCTD, the RNP antibody, although that can show up in a variety of different autoimmune diseases. I didn't talk about Sjogren's, but Sjogren's is an important cause of connective tissue disease, ILD, especially associated with SSA. And I also didn't mention it, but ANCA vasculitis, an unusual manifestation of, can be a UIP pattern ILD. So it can't hurt to actually send off and look for that MPO antibody, remembering that the MPO antibody is not super specific antibody. So that's my quick approach to looking for autoimmune diseases in someone presenting with ILD. Okay, we should probably go back to our case. Sweet.
What happened?
What's that? Oh, I forgot. Rupa and I have like practiced this so many different times, and she's still gonna have to whack me over the head from time to time because I forget to do something. A couple of pro tips. All right, so yeah, I told you. Oh goodness, just like want to get back to the case. Some pro tips, some quick ones. Often, for those of you like this, like for those of you practicing in the hospital, you know that rarely is the person going to walk in with classic dermatomyositis, right? So some things that you want to look for, like they're more subtle. So remember, they don't have to present with a classic Gottron's papules. Sometimes people can present with these weird rashes in places you don't expect, like on the flank here. So it's mild rash, and when you get dermatology biopsy, that interface dermatitis. Sometimes people can present with just Raynaud's and some hand tightness. Remember that, for the majority of people with primary Raynaud's, it's going to show up in the teenage years or in their early 20s. Someone who presents later in life with Raynaud's, that's a little unusual. Start thinking about connective tissue disease. And a final pro tip, don't be over-reliant on the ANA. So remember that, of course, an ANA is highly nonspecific and shows up in healthy people all the time. On the other hand, ANAs can be regularly negative in people with CTD, ILD. So of course, in rheumatoid arthritis, frequently ANA negative. But remember that myositis, the autoantigens that were being targeted are actually in the cytoplasm. So frequently people with inflammatory myositis are going to be ANA negative. So those are some key things just to remember as you're evaluating these patients. Okay, I think, yeah, I can get back to the patient now. Okay, sorry.
Okay, so Andy's come and seen the patient, pulmonary saw the patient, dermatology, as Andy recommended, there's a skin rash, and ultimately, together with the medicine team, all are suspecting dermatomyositis due to the constellation of findings. So one key teaching point here, as Andy referenced, is a lot of the diagnostic tests take a long time to come back. So in a hospitalized patient who's presenting acutely ill, don't wait to start treatment, and the first line would be pulse steroids, until you have a firm diagnosis. You can rule out infections or other sort of mimics of this, and then ultimately get started on treatment. So this patient, we started on Solu-Medrol on day 2. And then we did the rest of the workup for dermatomyositis, recognizing that the yield is highest early in the disease course. So you do want to start ordering these things. So she had a skin biopsy, showed interface dermatitis, and MRI thigh showed edema consistent with myositis. And eventually, 7 to 10 days later, her Jo-1 returns positive. Fortunately, she actually starts to get better with steroids. So that's wonderful. But then the medicine team appropriately asks us, well, is steroids enough, or do we have to add a steroid-sparing agent or a DMARD? So Andy, what do you think? This is a patient who has improved with steroids, is feeling better. What are your thoughts on adding additional immunosuppression?
Cool. Okay. So y'all, this part, Rupal and I, as Rupal said, we wanted to throw back the curtain on sort of what we do. So we wanted to kind of give you a flavor of the kind of discussions that we have about patients like this. So Rupal, you know that, of course, I like to be aggressive. I like to start DMARD agents and help get people off of steroids. But I feel like it's important to acknowledge the fact that there is that study from Murray et al. From 2011 that showed that more than 20% of people with inflammatory myositis-associated ILD got better with complete resolution of their CT scans with steroids alone. Can we do steroids alone?
Great point, Andy. And I can imagine that it's appealing to think about steroids alone. But my concern is this patient presented acutely. So 3 months, this is pretty aggressive. And unfortunately, we can't predict who is going to progress with dermatomyositis-related ILD. So we have a whole other 80% who we're concerned are going to progress. And in fact, in dermatomyositis, there is a small group of people who will unfortunately either die of their ILD or need transplant. So given how sick this patient is, I would favor additional treatment.
Totally agree. Okay. So, all right. So we think about treatment. So we're going to now go through some of the data. And it's actually one of the things that we'll highlight on here, that there's some randomized control studies, but relatively few. And because there's relatively few, there's really a lot of room for discussion because we just don't know. Okay, so Rupal, we always start with mycophenolate. We love mycophenolate. I love mycophenolate. But why do we start with mycophenolate?
Well, we love mycophenolate because it's well tolerated. There's also data from the scleroderma lung study that shows it's efficacious in scleroderma-related ILDs. And so extrapolating that data, we find that honestly, we reach for mycophenolate often in CTD ILD as our first line. Well tolerated, and we have data that shows efficacy, noting that it does take a while to work. So you are going to need steroids up front because CellCept alone is not enough to control somebody who's really active CTD ILD.
All right, so I totally agree. But as I mentioned, I like to be aggressive. Like, these are bad diseases. That CT looked bad. So Rupal, what do you think about adding a second agent? You know, often I reach for rituximab.
Great point. And we do combination therapy when people are really sick. I usually think of combination therapy in people who are not responding well to steroids or not improving, or diseases, as you mentioned, like MDA5 dermatomyositis that we know is going to rapidly progress. So in this patient who is improving with steroids, we think is doing well, I would favor holding off on a second agent, starting with steroids, adding CellCept, and kind of close follow-up over time.
Totally fair. Okay. So we're doing the mycophenolate, we didn't show it, but this person's rash is pretty bad. They're weak, didn't talk about it, but a little bit of trouble swallowing. So I'm worried about her from a myositis standpoint. We have excellent randomized control trial data from the ProDerm study showing IVIG works really well for the skin, really well for the muscles. So I think we should start that. Will it do anything for her lungs?
I don't know. There's not enough data here. It works fast, low side effects. I think it's totally worth throwing it on here when she clearly has myositis and skin disease.
Okay. All right. So we'll do the IVIG, we'll do the mycophenolate, we'll taper down the steroids, and we'll see her back in clinic in a couple months and see how she's doing. So Rupal, let's just say, like, thinking forward a couple of months, we're tapering down the steroids and she starts to get worse. More shortness of breath. We repeat this chest CT, it looks worse. So at that point, I think we should probably do a second level agent, right?
Yeah.
Okay, so we have a lot to choose from. We have rituximab, as I mentioned, we have tacrolimus, we have tofacitinib. We have tocilizumab that targets IL-6. How do I choose?
Now, this is where the beauty of our multidisciplinary conference and the discussion comes in, because all of these drugs do have some data in myositis, some as upfront therapy, some in combination therapy. None have really good randomized control data. And so a lot of our decision making then goes by extrapulmonary symptoms. So some of these drugs are better for skin disease or myositis. And so we might lean one way or the other. And it's really sort of patient specific.
Yeah, totally. Like mix and match. Okay, so we haven't yet talked about nintedanib and the INBUILD study.
Right. So we know from the INBUILD study, which was a study of people with progressive pulmonary fibrosis. So that includes people with CTD, ILD, but also other ILDs like hypersensitivity pneumonitis, that nintedanib slowed progression of fibrosis. And so Andy asked me a great question. What happens if they progress? And a lot of that is dependent on, do they progress and their CT looks really inflammatory, lots of ground glass, lots of consolidation, in which case what Andy and I just talked about, the immunosuppression is the right way to go. But unfortunately, some of these will progress over time into a more fibrotic pattern. They evolve sometimes from NSIP to UIP. And that's where I reach for nintedanib, because I think, oh, this patient is maybe going to become more and more fibrotic, and nintedanib is the right way to go to slow things down. And recognizing, again, that we're often doing many things at once for people who progress. So they're on immunosuppression, and then we're adding nintedanib as well.
Perfect. All right. So before we move on, we should probably talk about Cytoxan and azathioprine. Oldies but goodies. I know a lot of people use them, but we don't. Why not?
Yeah, I tend to stay away from Cytoxan. It has high toxicity. The really only time we use that is when someone's critically ill. We need something that will work fast, but CellCept shows equal efficacy and better tolerated. Azathioprine, there is data for azathioprine upfront. I think just as a center, we tend not to use it.
Yeah. All right. All right. So I'm going to quickly show references. Obviously, it's not for the room, but for those of you watching at home on YouTube, you just pause this, and if you want to look something up. Okay. So I wanted to talk briefly about, a fun topic, which is what's new on the horizon. And one of the big things that sort of the hot topics now is targeting B cells. So I already mentioned that rituximab, pretty effective in some, at least for some of these patients with inflammatory myositis. But other patients, it doesn't work that well or works slowly. So there's actually been a lot of effort at targeting B cells. And so there's the next generation of anti-CD20 antibodies. So obinutuzumab is one, ocrelizumab is another for MS, ofatumumab is another one. And what they all have in common is that they have a deeper level of B cell depletion. So rituximab, quite effective at depleting B cells in the blood, but not as effective in the tissues. Obinutuzumab, much more effective depletion of B cells in the tissues. And recently, while rituximab failed to show any improvement for lupus nephritis, obinutuzumab, a recent New England Journal study showing it was quite effective for lupus nephritis. So I think we're really all looking forward to seeing how obinutuzumab works in other autoimmune diseases, especially myositis. That being said, there's a caveat, which is that the probably infectious risk with obinutuzumab are a little bit higher than rituximab. Another new kid on the block is inebilizumab. Yes, that's a tongue twister. It targets anti-CD19. So CD19 is present on most of the cells that have CD20, but also plasmablasts and plasma cells. So now you're getting even a wider swath of the B cell population. That's been already approved for NMO and recently approved for IgG4 disease of all things. CAR T cell therapy. So probably many people have heard of this. So chimeric antigen receptor T cells. So these are T cells that have been taken out of the body and reprogrammed in a sense by putting a chimeric antigen receptor on them that can recognize CD20. You have to give people chemotherapy and then put the T cells back in. T cells proliferate. Patients can get a cytokine storm. We've seen this used commonly in people with B cell leukemia and lymphomas. People can get very sick, but then do quite well. And intriguingly, in some small studies of CAR T cells in autoimmune disease, people have gotten CAR T cell therapy and then have been off drug for up to 2 years in remission, which is pretty exciting. But that's a lot of rigmarole to give someone a CAR T cell. So one newer thing is BiTE therapy. So bispecific T cell engagers. So this is an antibody with one arm recognizing CD3 and the other arm recognizing something else, either CD20 or BCMA, which is on plasma cells. The BCMA has actually been used effectively for multiple myeloma. And recently there was a New England Journal letter showing that in a number of people with autoimmune disease, this worked really well. So you don't have to take the T cells out and reprogram and all that stuff. You just give the antibody and people respond. So it'll be interesting to see what studies of this show. So ongoing studies right now, including we're starting up some studies of CAR T cell therapy for autoimmune disease at UCSF. So that's what's on the horizon. Let's finish off this case and move to a second case.
All right, so just to wrap up this case, what we did for this patient, she got the pulsatile steroids, started on CellCept, got IVIG. As an outpatient, we've slowly tapered her steroids. She remains on CellCept. And this is what I consider a success story in my clinic, right? Like we come in really sick, on fire, and I get to see them a couple of years later, not on oxygen, living a normal life, raising a family. It's really, I would say these are some of the most rewarding patients that I see. Okay, we wanted to present also a case you might see in outpatient clinic. So here's the other side of the coin. Mr. M, 72-year-old, presents with mild shortness of breath that's progressed over the past 2 years and is a little frustrated, has been to lots of doctors for this shortness of breath. And initially someone said, oh, this is COPD. Often this happens even if the patient never smoked and take some inhalers, come back. Well, that didn't work. Okay, now this is probably ischemic heart disease. Gets a cardiac stress echo, that's negative too. Ultimately comes to you and says, what the heck is going on with my shortness of breath? At first it was just inclines, but now I'm noticing it all the time. And then you on your review of the systems are like, you also notice that the patient has a little bit of soreness in their hand and wrist joints. So just taking a step back, when you should suspect ILD, one of the reasons that ILD is so difficult to pick up is the symptoms are really nonspecific and can often be mistaken for obstructive lung disease or cardiac disease because it's shortness of breath and cough. Rarely we see clubbing, usually when disease is advanced. On exam, you really get crackles at the very bases. So if you're not listening all the way at the bottom, you often can miss them. And so on my soapbox for all of you is to keep this on your differential. We often get patients who have had multiple tests over a couple years and then ultimately get pulmonary function tests that show restriction and then get a CT scan that shows ILD. So I know that all of you will diagnose it much faster. So in this patient, you do that, you get a CT scan and it shows reticulation, traction, and honeycombing. Going back to our earlier in the slide, this is a UIP pattern. You're already thinking, okay, this could be IPF, but because this patient has some joint pain, maybe it's rheumatoid arthritis and I should refer to rheumatology as well as ILD clinic for further evaluation. So Andy, back to you.
Sure. All right, so remember the slides before. So I'm starting with the CT, starting with the pattern, the UIP. So if you remember back, so that's especially rheumatoid arthritis, but thinking about other autoimmune diseases, especially scleroderma. So I do my whole review of systems. I do my physical exam. I do get appropriate labs. In this particular case, patient ends up having mild joint swelling, his MCPs and wrists, so rheumatoid arthritis-like. He ends up being CCP positive. He even has some erosive changes on his x-rays. Okay, so rheumatoid arthritis. Great. Now what? Okay, so right away, I'm concerned because we know from a number of different studies, including a study from San Francisco General, that people with rheumatoid arthritis, ILD, have a much higher mortality rate than people without ILD who have rheumatoid arthritis. So right away, I'm concerned about him and I'm thinking about treatment. But as I start talking with him, this just happened the other day, the guy's like, doc, I'm not that short of breath. Yeah, I'm a little winded if I walk up a hill. But do I really have to start treatments? He really didn't want to. Rupal, what do we tell him?
Yeah, I get this all the time, particularly because all the drugs have side effects. They're not easy to tolerate. But what I tell patients is, although there's a small fraction of patients with rheumatoid arthritis-related ILD that don't progress. You can see here on this graph, we're looking at over 80% of patients that will progress and a subset who will really progress quite dramatically. And because we're not refined enough yet to say, oh, you're in this 14%, we recommend treating everyone. So here we are back to our usual discussion. How should we treat this patient? So when we think about treatment of RA-ILD, Andy, often we think about immunosuppression. We've been talking about immunosuppression for connective tissue disease through this whole talk. And there's data, as we've suggested before, for all of these agents in different types of connective tissue disease and some data in rheumatoid arthritis-related ILD. And we know that Joyce Lee and colleagues did a study of rheumatoid arthritis-related ILD. And what's important about this study is that she included patients with RA who had a UIP pattern. And that's important because we know from other data that patients with UIP who have IPF actually do worse with immunosuppression. So then we start to wonder, like, is immunosuppression the right thing? But in this study where she included patients with UIP and sort of all types of immunosuppression, Ritux, AZA, CellCept, they actually found stability in the lung function after starting immunosuppression. So I would say this data might support us starting immunosuppression. What are your thoughts?
All right, so that was totally my thought probably several years ago. But Rupal, as you know, as we've had these discussions over and over in the ILD conference, started to change my thinking on this. So, all right, so antifibrotics. So, you know, one of the things I'm impressed with is that UIP pattern, that UIP pattern we saw in that patient, that looks exactly like IPF. These patients progress slowly, just like IPF. When you look at genetic studies of IPF, there's polymorphisms that you see strongly associated with IPF that show up in more than half of people with RA-ILD. So there's so much of this that really feels so equivalent to IPF. And we know the antifibrotics work well for IPF, you know, so that's been shown with pirfenidone and nintedanib. So pirfenidone was actually studied in a beautiful randomized controlled trial for RA-ILD, and it is such a bummer that the pandemic destroyed the enrollment and it ended up closing early and we didn't find out anything. We already mentioned the INBUILD study that looked at antifibrotics in people with CTD-ILD, showing that they're effective in people who have a UIP pattern especially. And in a subgroup analysis, while it wasn't statistically significant, it certainly seemed like people with rheumatoid arthritis did quite well with antifibrotics. So for all those different reasons, I've been really kind of like thinking more and more like we should have these people on antifibrotics. That being said, the INBUILD study also said that people seem to do a little bit better when they're on the antifibrotic with an immunosuppressive drug. So, all right, so back to our case. So, all right, so nintedanib?
I agree in nintedanib, and I think you kind of hit the nail on the head for what our field is grappling with is all UIP act the same or does it not? And there's a lot of evidence gap here, but I would say in general as a group, we are treating with antifibrotics more commonly when people are presenting with UIP patterns. Totally. So I'm all for nintedanib, but they still have
rheumatoid arthritis, yeah. All right, so for the rheumatoid arthritis, you know, so methotrexate or first line, anti-TNF second line, but those aren't going to do anything for that. All right, so some people I put on anti-TNF for their RA and mycophenolate, do that. Tocilizumab is approved for treatment of RA. You know, it's only been studied retrospective and not very well in RA-ILD. But rituximab has been studied retrospectively in a whole bunch of studies and seems to be okay for our RA-ILD and does work for rheumatoid arthritis. So one-stop shopping, rituximab?
Yeah, I vote one-stop shopping, also recognizing that CellCept doesn't work well for the arthritis, which is why you would recommend two agents. So let's talk to the patient, see what they want to do, but toci or rituximab sounds like reasonable with nintedanib.
Yeah, I totally agree. And, you know, ultimately, because we're so lacking in data, yeah, we're really going to rely on the patient.
Yeah. Sounds great.
Cool.
Okay, we hope you've enjoyed this sort of back and forth because this is what we do on a weekly basis. And it really is wonderful to have partnerships when you're thinking about challenging patients and evidence gaps. We just wanted to close and say that we really think of treating CTD-ILD as a team sport and really rely on our primary care colleagues as well. There's a lot of things that those of you in primary care can do to help us. But in conclusion for our section, you can see that there's a need for a lot of evidence and better understanding of these. So we're really lucky to work with Dr. Shum, whose science is really focused on better understanding CTD-ILD and helping us refine treatment. So we're going to turn it over to him. Thank you.
Okay. So, given all of the challenges that Rupal and Andy have sort of set forth in our management of CTD-ILD patients, what can we do with research to define new and more effective therapies for CTD-ILD? So I'm going to tell you about an approach my lab has taken to study families with CTD-ILD to see if we can identify new genes or new molecular pathways that are involved in disease and could be targeted in treatment. And so the family I'm going to tell you about today is one that was actually recently profiled by UCSF News on the website here a couple of months ago, in part because of their strong commitment and contributions to the studies of CTD-ILD in my lab. I met the family about 14 years ago when Latasha, seated here to the left, was admitted to UCSF Hospital with a flare of her interstitial lung disease. I had learned at the time that she had been diagnosed as a child with juvenile rheumatoid arthritis and ILD, and then her sister had the exact same thing, also diagnosed with GRA and ILD. And this is their pedigree here. This is Latasha and Christina, and then this is an aunt they had, also a UCSF patient, who unfortunately succumbed to her CTD-ILD several years before. So in 2013, we decided to use a research tool called whole exome sequencing to see if we could identify a gene that's causing their disease. Now, that's something that we can now just send from the clinic, or you can send from the inpatient service. But in 2013, it was a research tool. We sequenced the family as well as 4 additional families found throughout the US. And in collaboration with Baylor College of Medicine, we identified the gene that's causing their disease. And it was a mutation in this gene called COPA, which was really exciting because we had defined a new monogenic autoimmune ILD and arthritis. And so this really set us off on this research path to try to figure out how does mutations in COPA actually cause CTD-ILD. So just to remind you, first of all, what does COPA do and what is it? I had to remind myself. So take you back to cell biology in college or medical school. You'll recall that COPA is a protein that's part of this COP1 vesicle. Okay, and every single cell of our body has this. COP1 vesicles and COP2 vesicles are responsible for basically shuttling proteins between the endoplasmic reticulum and the Golgi in our cells. And specifically, what COPA does is it actually is responsible for retrieving a certain class of cargo proteins from the Golgi back to the endoplasmic reticulum. So that's really interesting, but it remained a mystery. How does this cause CTD-ILD? And the challenge was that COPA had never been implicated in an immune disease, never been implicated in a lung disease. How exactly was it causing CTD-ILD? Now, a major clue came a couple of years later as we were studying this in the lab, where collaborators from Japan and Italy called us and said, you know what, you should think about this protein STING being involved in COPA syndrome. And the reason why is because they told us that COPA syndrome presents very similar to a different monogenic disorder of autoimmune ILD called SAVI, or STING-associated vasculopathy with onset in infancy. And these are the CT scans of a COPA syndrome patient and a SAVI patient, both very similar. SAVI patients also present as kids. Interstitial lung disease is really the defining manifestation of their disease. They have arthritis and they have capillaritis, which is also seen in COPA syndrome. So to figure out if STING was involved in COPA syndrome, we turned to our mouse model. So we made mice that have the exact same mutation as patients. And remarkably, these mice spontaneously developed ILD or CTD-ILD that was really mirroring what we were seeing in patients. So this is an H&E scan from a mouse lung, and the alveolar spaces are completely filled with inflammatory fluid. There's inflammation sort of percolating through the interstitium. We then, we then generated mice, same COPA mice, but lacked the STING protein. So basically STING deficient mice. And remarkably, all of the interstitial lung disease went away, as well as all the systemic inflammation in the mice went away. And so this really led us to define sort of the molecular pathogenesis of why COPA syndrome happens, and taught us that COPA syndrome involves activation of this immune pathway called the cGAS-STING signaling pathway. So what is that? Well, some of you may be familiar with it. It's an innate immune signaling pathway that each of us has and is really important for helping us to eradicate infections, particularly viral infections. So what is it? What happens? How does it work? So if you get infected with a virus, say a DNA virus, that virus is sensed in cells through this enzyme called cGAS, which sits in the cytosol. It binds the DNA from the virus and creates this ligand, which is a ligand for the STING protein. The STING protein resides in the endoplasmic reticulum as a dimer, and then once it binds its ligand, it traffics through COP2 vesicles to the Golgi, where it then begins to multimerize and then basically activate downstream signaling program that leads to inflammation. And the inflammation, the canonical type of inflammation it leads to is these type 1 interferons, which many of you know are sort of really important for eradicating viral infections. So what had not been known at the time is that STING actually, in order to help turn the signal off, it requires the presence of COP1 vesicles to help retrieve it from the Golgi back to the endoplasmic reticulum. And what happens if you don't have a functioning COPA protein, that STING begins to accumulate on the Golgi apparatus and then constitutively signal. So you get chronic inflammation and constitutive inflammation by STING, leading to sort of systemic type 1 interferon secretion, as well as other inflammatory cytokines. Okay, so that was the molecular pathogenesis of COPA syndrome, but how does actually CTD-ILD happen? Okay, so we spent a few years trying to work out in mice how exactly CTD-ILD happens because of the STING activation. And I'll just tell you that part of our clues came from important clinical observations in our patients. Okay, the first is that there seems to be a disconnect between the development of the ILD and the inflammation, sometimes, not always, but sometimes. And we see this in children who develop cystic lung disease early in life prior to developing any systemic inflammation. And then we also see this clinically when we treat patients, and we note that the interstitial lung disease can progress despite immunosuppression. So this patient, prior to 2015, came in with repeated episodes of flares of the interstitial lung disease, mostly manifested by diffuse alveolar hemorrhage. Once we put them on high-dose immunosuppression, mycophenolate, the drug you heard about earlier, we were able to basically stabilize the disease, no more flares. But despite treatment, you can see that over time, the interstitial lung disease completely progresses, increased levels of cysts and increased fibrosis. So working in mice, we and other groups have really tried to figure out the mechanisms of disease. I won't show you a bunch of mouse studies, but I'll really just sort of summarize the important insights that we and others have made. The first, T cells are important drivers of disease. And that's likely one reason why drugs that target the adaptive immune system, like mycophenolate and rituximab, are effective. They can get rid of the flares of disease, but they're only effective to a point, okay? And the reason why is because there's not only dysregulation of the immune system, there's also problems with activation of STING within the lung tissue itself. So STING activation in epithelial cells of the lung, other structural cells like fibroblasts and endothelial cells actually contribute to disease. Okay, so we figured out some of the critical cell types that are involved in CTD-ILD. But mice are not people. And all of this research, of course, is geared towards trying to figure out how do we come up with a cure for Copa syndrome and potentially other CTD ILDs. So the last few years, what we've been focusing on is this idea of incomplete penetrance in Copa syndrome. So what does that mean? So we noticed in all of the families that we were studying worldwide that there are a number of individuals who carry a pathogenic Copa mutation shown in blue, but appear to be otherwise healthy. They don't seem to have any evidence of disease. So why is that? So that's incomplete penetrance. Okay, we found a number of these subjects throughout the world. We found 9 subjects in total and sort of set off to see if we could understand why these patients with these individuals were protected. Would this lead us to a potential cure for Copa syndrome disease? So the first thing we needed to do is just make sure they didn't actually have Copa syndrome. Did they just have a mild form of it or just sort of reduced inflammation? So the way we worked on that is we analyzed their medical data. We went deeply into the charts and basically looked at every single aspect of Copa syndrome to really clarify that they had no evidence of disease at all. They were otherwise relatively healthy. Even our subjects who are like 60, 70 years old. Those who had even undergone CT scans had no evidence of Copa syndrome in their lung, and none of them had ever required any use of immunosuppression, whereas any of our patients required not just like pulse immunosuppression, but sort of heavy levels of mycophenolate, rituximab, these other drugs. Okay, so we confirmed that clinically, these carriers had no evidence of disease at all. They were otherwise relatively healthy. Could we then look in their blood and sort of confirm they didn't have any of the molecular hallmarks of Copa syndrome? So we did this a number of different ways. We looked for type 1 interferon signatures in the PBMCs. None of the carriers had an elevation of that. None of them had any elevation of interferon cytokines in their blood. And then we looked more directly at evidence of STING activation. And you can see from this flow cytometry plot that all of our subjects, all of our patients, despite being on high-dose immunosuppression, have higher levels of STING activation, not seen in our unaffected carriers or our controls. So overall, we were able to confirm that carriers had no clinical evidence of disease, no molecular hallmarks of Copa syndrome. Why not? They had a pathogenic Copa mutation. What's protecting them? We began to read the literature and notice that people were talking about differences in STING alleles that are found in people worldwide, and some of the differences in function that some of these STING alleles have. And we became particularly interested in this haplotype of STING called HAQ, okay, indicated by the amino acids, the SNPs that change the amino acids located here throughout the protein and sort of mapped onto the crystal structure of the HAQ dimer, okay? And I say believed to have reduced function because prior to our work, it was actually quite controversial. Some people published studies that said HAQ had reduced function. Other people said, you guys are crazy. HAQ STING functioned normally, okay? But we hypothesized that maybe unaffected carriers never developed disease because of differences in their STING alleles, in part because all of the work we had done in mice and in patient cells to show those sort of the critical importance of the STING protein. So we did this in a number of ways, but this is really the summary data here. We basically conclusively showed that HAQ STING is this factor, which is the single factor which completely protects patients or Copa carriers from developing disease. We did unbiased genetic analysis as well as targeted sequencing to show this, and then we did a tremendous amount of work, functional work in vitro to show that HAQ STING protected our patients. The most cool thing we did, which unfortunately I'm not showing here, is we took lung cells from a Copa syndrome patient. We expressed the HAQ STING allele in those cells and could rescue the inflammation, sort of proving that it works. Okay, so how have we used genetics in studying families with CTD-ILD to understand sort of new molecular pathways involved in disease and potentially new targets? Through our work of the Copa syndrome we've really clarified that STING is central to the ILD, at least in COPA syndrome patients. We're very interested in understanding whether STING might be associated with scleroderma ILD, myositis ILD, other things. This unique discovery that HAQ STING is actually keeping other COPA carriers completely healthy really suggests to us that it could be developed and used as a gene therapy for COPA syndrome, and something my lab is very interested in doing. And then because we've identified the specific molecular pathway that's dysregulated, this does provide some promise for patients that targeting the cGAS-STING signaling pathway through drugs being developed by pharma might be a new treatment for COPA syndrome. All right, so that comes to the end of our talk. I think I speak for all of us when I say that we are grateful for the patients who not only involved in the research, but who allow us to be sort of a part of their care and show us all of the courage and grace they have to sort of be resilient through this journey. This is a team sport, like Rupal talked about. This couldn't be done just by pulmonologists or rheumatologists. We work closely with dermatologists. We have a multidisciplinary conference on Fridays where we work closely with thoracic radiologists that specialize in ILD, as well as pathologists that specialize in ILD. I'd like to thank the members of my lab, all of our international collaborators that helped us with the research. And then, of course, none of this also could happen without the staff of the rheumatology and ILD clinics. And we'll take questions. Thank you.
That was wonderful. A real tour de force. I'll start with just a couple of questions of my own, and then happy to throw it out to the audience as well. So I guess, Dr. Shum, starting with your section of the talk, super interesting to hear about COPA syndrome and the work that you're doing. Can you give us a sense of sort of the broader milieu of mutations like that? Like, are a lot of types of CTD ILD related to mutations like that, or are we still primarily treating phenotypes based on CT scans and antibodies that come back?
Yeah, it's a great question. I mean, I think ILDs are rare diseases. COPA syndrome is an ultra rare disease. So like there's only 100 patients that have been published in the literature. But we do obviously think that sort of pinpointing specific molecular pathways with these families can help provide insight into other types of CTD ILDs. And I would say that there is evidence that, for instance, scleroderma ILD involves the cGAS-STING pathway. So we're interested in translating our results there. But yeah, I think we are not sequencing all of our patients and figuring out specific treatments. This is sort of just where we're headed to next.
Really, really exciting stuff. One more question that I had was kind of when you talk about, for Dr. Shah and Dr. Gross, when you're talking about kind of clinical response to therapy, is it primarily how they're doing from like a hypoxemia standpoint, or are you looking at CT scans, and at what juncture? I would imagine the findings kind of lag as they do in infectious pneumonia. So how often are you rescanning people? And
yeah, this is a great question about disease monitoring. And counseling patients on what to expect. So in general, we rely on pulmonary function tests to really monitor disease, trying not to expose patients to too many CT scans. So I usually get pulmonary function tests usually every 3 months when I'm starting treatment to make sure that there is response, and then every 6 months going forward. And then I get CT scans usually in the beginning, again, within 6 to 12 months to monitor response, and then as needed based on clinical change. In terms of counseling patients with ILD, this is a real challenge. Our hope, of course, is that a lot of these are inflammatory and will improve. What we see in practice is that some of these continue to have fibrosis or some long-term damage, and then others will continue to progress, like our second case. And so counseling about prognosis becomes sort of in evolution as you see how people respond and what the trajectory is. And I'll pause and see if either of you want to add anything there.
Yeah, I guess one thing I'll add to that is I think we've both shared patients. I've shared patients with both of you guys or it can take a long time to figure out that a person's progressing. Like, so I think one thing I wanted to emphasize to everyone is that following the PFTs every 6 months, like that's every 6 months for years. And if you lose track of that, people can actually get a lot worse.
Yes, that's really important because sometimes these people are young, they want to live normal lives, they don't want to be tied to medical therapy. But when that happens, it can be really challenging when people come back to care and are much worse. So as a group, we encourage everyone you see with ILD to really continue to have disease monitoring for the rest of their life, essentially.
Great. We have time for one quick question, if there are any from the in-person audience. Great. Let me get you the mic.
Yeah, actually, Andy, I was curious. We used to have an entity called rheumatoid lung, I think, that I, learned about in training. Is that a different entity than RAILD, or is that just a new name for an old?
Yeah. So rheumatoid arthritis has a lot of different manifestations in the lung, but by far and away the most common is that UIP pattern ILD. So I think mostly what people were talking about the past with a lot of pulmonary, it was the fibrosis that we see with the UIP pattern. That being said, people can get bronchiectasis, they can get organized pneumonias. There's a lot of different things that show up, but I think the most dangerous and the most important thing for everyone to be aware of is that UIP pattern.
Great. Well, thank you so much. We're at the top of the hour, so happy to take further questions up here. Thank you.